Okay, I want to talk about access site complications, particularly femoral access complications. I want to start with some anatomy tips. Whenever we get femoral access, we always obtain an ipsilateral oblique 30-degree angiography. For example, RAO for a right femoral stick. That RAO will open up the common femoral bifurcation. It will show exactly the split between the profunda and SFA. And if it doesn't show it well, you can go steeper RAO. And the common femoral artery that we want to stick, we aim to stick, extends between that bifurcation and the bottom of the inferior epigastric artery. You should always recognize that inferior epigastric artery, it has a loop, and the bottom of that loop define the junction between common femoral and external iliac artery. The bottom of that loop touches the inguinal ligament, which defines the separation between common femoral and external iliac artery. Now, 2D angiography is deceiving, and I want you to understand why that separation between femoral and iliac is so important. If you look from the side laterally, you will see that immediately upon that inferior epigastric artery, the artery, which is an iliac artery, takes a very deep and sharp dive into the pelvis. So stick even just above that inguinal ligament is actually a stick into a loose, non-constrained space where you can bleed massively and sequester a large amount of blood before you get any self-tamponade. So you can have a large free-flowing bleed with any stick above this area. You have a 5 to 17 times higher risk of what we call pelvic or retroperitoneal bleed. So very important to understand the 3D imaging, why this point here is much deeper than that point here and much more risky in terms of bleeding than that point here. You may not appreciate it on 2D angiography. Another idea is the profunda. Again, on 2D angiography, the profunda looks lateral to the SFA, which is true. But in fact, it's not just lateral. Even at its takeoff, it takes a sharp, deep posterior dive into the thigh, where it's very hard to compress. Even a stick in the proximal profunda is already too deep in the thigh and cannot be compressed. It may bleed incessantly. That's why a stick in the profunda, even a proximal profunda, is a high-risk stick. So profunda and iliac stick are very high-risk sticks. We don't want to stick the SFA, but SFA at least is more superficial and it's less risky of a stick than those other two. And this is an illustration from a CT scan that shows you what I'm talking about. So here you see on AP imaging how they look. And then if we go laterally, look how this is the common femoral. And this is how it takes a very deep, sharp dive above the inguinal ligament into that loose, non-constraining pelvis, where you can bleed many liters of blood before the bleeding stops. Also, you can see how the profunda takes a sharp posterior takeoff dive into the thigh. Regarding access under ultrasound, we aim to see the SFA and the profunda, those two circles, and we aim to see how they join upward. As we're scanning upward, we aim to see how they become one circle, common femoral artery, and we stick the common femoral artery on short axis view. However, I want you to be able to recognize how can you tell the iliac on ultrasound. Most fellows don't know. They can tell SFA profunda, common femoral. They cannot tell the iliac. You need to keep scanning up, and the point where that common femoral dives, takes a dip down, this is the iliac point. And this is better identified in longitudinal ultrasound. And fellows need to be more facile with doing longitudinal ultrasound as well. So this is on longitudinal ultrasound. You see common femoral splitting into SFA anteriorly and profunda posteriorly. If you keep scanning upward, you'll see the artery make a sharp turn and dip into the pelvis, and this is where you become iliac. So you need to stick before that deep turn. And in difficult cases, especially there are some patients who have a very small common femoral or very short common femoral artery where you see the bifurcation, then you see quickly it bends down. So in those cases, it's hard to nail the actual common femoral. And I encourage you in those cases to maybe sometimes stick under longitudinal ultrasound. And keep in mind in those cases, sometimes I worry, you see on the ultrasound this, and you aim to stick that, not that. But the problem, your needle is too shallow and your needle will enter higher up outside your ultrasound field. That's why I encourage you, especially in those difficult cases where you have a short common femoral artery, consider longitudinal ultrasound and also make your needle steep and nearly vertical, parallel to the probe. So you keep seeing it stepped and make sure it's going to the common femoral, whether on short or long axis, because if you go shallow, your tip will go into the iliac and you may not realize it. And in difficult cases, again, consider sticking under longitudinal ultrasound. Additional anatomic tips. On the common femoral level, there are two arteries you need to be familiar with. There is the inferior epigastric that delineates and separates the common femoral from the external iliac, the bottom of it. And you have another one, iliac circumflex. Both those arteries are important if you have iliac disease or common femoral occlusion because they provide collaterals. They are also important because they can be a source of retroperitoneal bleed. One of those situations is micropuncture access. So when we access via micropuncture, it's not uncommon for that flimsy micropuncture straight tip wire to go into that iliac circumflex. So whenever you encounter difficulty advancing the wire, always fluoro. And if it's going that direction, you know you're going into that. Don't keep pushing. You will have a pelvic bleed if you keep pushing. That's one of the causes of RP bleed. Another cause is inferior epigastric. On occasion, somebody may stick through and through the inferior epigastric into the common femoral artery, and I've seen that complication. And then when you take the sheath out, you will have a massive bleed from the inferior epigastric. So be familiar with those arteries. Another anatomy tip is we all know at the common femoral level, the common femoral artery is more lateral to the vein. The vein is more medial. But you need to realize that quickly at the SFA level, the femoral vein quickly crosses under the artery and becomes posterior, then lateral to the SFA and to the popliteal artery. So actually at a low stick level at the superficial femoral artery, the artery and veins are superimposed, the vein being posterior to the artery. And the venous stick, let's say you're putting a venous sheath, a venous stick can go through the artery and cause an AV fistula. And even an arterial stick can cause an AV fistula if you have a posterior wall SFA stick that may touch the femoral vein. So an arterial stick can cause an AV fistula, especially a posterior wall arterial stick, and definitely a venous stick can cause AV fistula. So that is a source of complication. Understand this anatomy. The vein goes from medial, the classic medial, to posterior, to lateral to the artery. Now, a question that arises, when you have a high stick, it's hard to compress the artery with manual compression when you have a high stick here. So somebody may ask, okay, for a high stick, maybe closure device is safer than manual compression? Very important board question. Well, the answer is no. Based on data, the answer is no. So this is one series that shows that actually angiocelia has a 3 times higher risk of RP bleed than manual compression. This is another series that shows that both perclose and angiocelia have higher risk of RP bleed than manual compression. And here's one of the explanations. Remember, for example, angioceal. Angioceal aims to deliver a plug on top of the artery. Well, when you have a deep stick, that plug frequently gets stuck somewhere along the fascia and muscle and subcutaneous tissue on top of the artery. It doesn't reach the top of the artery. It gets stuck here. So it doesn't achieve hemostasis. And sometimes it can achieve either partial or temporary hemostasis because it can shrink. The tension created by the device can shrink and approximate the muscles and fascia on top of the artery, and that approximation can create a temporary or partial hemostasis, but then the patient bleeds potentially massively later on. The same thing can happen with perclose. The idea with perclose is that you're delivering a suture over the arteriotomy. You're tying the arteriotomy, and you're tying a knot from here, and you deliver that knot all the way down to the arteriotomy. But again, if your stick is too deep, that knot before reaching the artery may get tied somewhere higher up. So keep those ideas in mind. Closure devices do not reduce the risk of RP bleed, including in high sticks. So what do I do in those cases? I may use closure device, but if I use a closure device, I don't just rely on it. I would do closure device, and I would add 30 minutes of manual compression on top of closure device, and I would closely monitor the patient post-op and keep a high level of alertness for any hypotension or lower quadrant discomfort. The board answer is, when you have high stick, is manual compression, not closure device. Along those lines, regarding closure devices, compared to manual compression, femoral access closure devices are associated with question, less bleeding or less vascular complications. That's a board question, interventional board question. And the board answer is no, neither one of those. Closure devices are meant to improve patient and physician comfort and accelerate patient ambulation, but doesn't reduce bleeding or vascular complications. In fact, based on a classic meta-analysis from 2004, old, closure devices were associated with the increased risk of hematoma, 1.84 times, and pseudoaneurysm and limb ischemia. Now, the effect was neutral in the modern randomized trial, ESAR closure trial, published in 2014. It wasn't better, it was neutral, manual compression versus closure device. So, but it definitely does not reduce bleeding or vascular complication, and it likely increases those complications, any closure device. That's kind of the board answer for that. Now, I want to quickly talk about superficial groin hematoma before diving into the more important complications. So if you have, the nurse calls you for superficial groin bleed hematoma, the treatment is immediate and timely manual compression for over 20-30 minutes. Immediate. You don't discuss over the phone what to do. You just go and hold manual occlusive pressure. Along with that, if the patient is hypotensive, you give fluids plus or minus atropine if he's having a vagal reaction. If he's bradycardic or relatively bradycardic, he's hypotensive and his pulse is 65. That's relative bradycardia. So you give fluid and a plus or minus atropine. This will control the bleeding in the overwhelming majority of patients. Important idea that comes up: do not use fem-stop to control the bleeding. Fem-stop, for those who don't know, is a compression device that you inflate over the arteriotomy. It's kind of similar to the TR band, if you want, for the groin. The idea, though, is that you don't use that device to stop the bleeding. If somebody's having hematoma, you don't put that to stop the bleeding. You stop the bleeding via manual compression, 100%. You can only use that fem-stop after you have stopped the bleeding. The bleeding is controlled. There is no longer hematoma. The hematoma is soft. You've watched the patient for a few minutes, and it looks like the hematoma is controlled and the patient is stable hemodynamically, then you apply the fem-stop potentially to reduce the risk of rebleeding, to prevent rebleeding, not to control it. And you can put it on at 0 millimeter of mercury. You don't need to inflate it above systolic blood pressure. You can put it on after you've controlled the bleed at 0 or mild amount of pressure, 40, 50 millimeter of mercury, just to prevent rebleed, kind of like a sandbag. Rarely for those superficial hematomas, if hemodynamics do not stabilize despite hematoma control, then you have to absolutely think of RP bleed that you're not seeing in the pelvis, and you take the patient immediately to the cath lab when hemodynamics do not stabilize, and I will explain that furthermore. Or very rarely, if the bleeding, the hematoma keeps growing despite you compressing it, well, one, you're probably not compressing it properly. Ask for help here, and you may need 2 people to help with the compression. But if truly you cannot control it with compression, then you may consider taking the patient back to the lab for contralateral access and angiography, as we do with RP bleed. So now I want to talk about retroperitoneal bleed. But before, I want you to be aware of the differential diagnosis of hypotension during or after PCI. Whenever somebody is hypotensive during or after PCI, you have 2 big categories, either coronary complication or access complication. So it could be access complication, whether an obvious hematoma or an retroperitoneal RP bleed, or it could be coronary complications, such as coronary perforation with tamponade, hence think of echo, acute stent thrombosis or occlusive edge dissection, which is diagnosed often by EKG, or it could be guide dissection, unrelated to wherever you actually stented, left main or RCA guide dissection, which will lead to a large infarct and a lot of hemodynamic compromise. This is usually also diagnosed by EKG. So those are coronary complications that you should always think of, those 3, and you have access site complications. You have the more benign issues, such as vagal shock from pain upon sheath removal, where you will have a relative bradycardia and nausea. You may have also side effect of excessive use of sedative or hypertensive in heart failure, or the patient is hypovolemic, plus you're giving him sedatives. Those are the more benign ones that may resolve quickly with either atropine or fluids. But think especially of those bigger 2 categories. So now I want to talk about retroperitoneal hematoma during or post-cath. It can happen in up to 0.5% of transfemoral PCI. And how do you diagnose this or think about it? Whenever you have hypotension or bradycardia, vagal shock, or sinus tachycardia with no suspicion of coronary complications on quick EKG plus or minus bedside echo, and or the patient has flank or lower quadrant fullness, swelling, and tenderness, which in one paper was 100% sensitive, that side swelling, fullness, and tenderness. You don't see hematoma. You see kind of induration or swelling of their side, ipsilateral side. And the patient may have also pain in that area in 64% of the time. Importantly, in retroperitoneal bleed, groin hematoma is frequently absent, so don't rely on that. Look for that flank swelling, flank pain, or unexplained hemodynamics. Those should immediately make you think of retroperitoneal hematoma, especially if you have high alert from the fact that your stick was a little bit high. So whenever you have any of those 3 here, especially the combination, you consider it clinically retroperitoneal bleed until proven otherwise, and you start your immediate treatment for so. You give an immediate fluid bolus wide open, 0.5 to a liter, And simultaneously, you try to do high groin hematoma compression, even if you don't see an actual hematoma. Now, this may not help a whole lot, but it may help a little bit. So you try to do that to provide some tamponade to the bleeding. So immediate fluid, high groin compression, and simultaneously do those things. You tap and cross for right blood cell transfusion. Remember, your hemoglobin is not going to drop immediately. You're expecting you will need a blood transfusion. You give protamine if your ACT is still over 150, if you can, and you give platelet transfusion, or at least consider them if 2B3A inhibitor is currently used or has been used in the last hour. So that's what you do immediately to stabilize the patient. Fluid resuscitation, manual compression. Do not order CT scan for this constellation of finding. The most common error and the most common reflex whenever somebody thinks of retroperitoneal hematoma is CT scan. Wrong answer. Do not do CT scan in an acute suspicion of retroperitoneal hematoma. I would say almost always avoid doing it the same day. Just do it next. If you want to do it, you may potentially do it next day. Do not do CT scan acutely in retroperitoneal hematoma, even if the patient is stable. CT scan is the best way to destabilize a patient with RP bleed during transport and during delay and during shaking the patient from one bed to the other. And it's a way of delaying proper care should he destabilize, delaying fluid resuscitation, compression, and delaying taking him back to the cath lab if he continues to decompensate. Do not do CT scan acutely. Now, the retroperitoneal bleed may stop via self-tamponade, and patient may stabilize with that initial fluid resuscitation, compression, and maybe blood transfusion and platelet transfusion, and protamine to reverse anticoagulation. So the RP bleed may self-tamponade with that initial resuscitation. So within an hour, his hemodynamics are stable. You've given him 1 liter, 2 liters of fluid. So it's good. We can keep watching the patient. The patient will likely require transfusion based on subsequent hemoglobin levels that will likely decline. And in a Cleveland Clinic registry, 58% of RP bleed eventually required transfusion. Keep in mind that immediate hemoglobin check will underestimate the bleed because the blood has not been diluted yet. So after initial quick fluid resuscitation and compression, if within that early phase, those first 20 minutes, you still have persistent hypotension, urgently take back the patient to the cath lab and obtain contralateral access to do angiography and potential treatment. Interestingly, only 5 to 16% require invasive or surgical treatment, meaning most patients do stabilize with just that resuscitation within those first 20 minutes. But those first 20 minutes are critical for you to make a decision. We do not delay treatment of such a patient. We make decisions quickly, resuscitation quickly, and decisions quickly. And those numbers are based on 2 landmark registry, one from Cleveland Clinic in 2006 and one from Journal of Vascular Surgery in the late 90s. In that 1994 paper, 16% required operation or intervention. And this is what they say. The retroperitoneal space appears to be able to sequester large amounts of blood, meaning several liters of blood, and tamponade will eventually occur in virtually all patients if they don't die, and if blood replacement and basically fluid resuscitation is adequate. So those are other ideas. Do not do CT scan in this initial unstable phase, even if the patient is or becomes hemodynamically stable. Even if you do resuscitation and half an hour later, the patient is stable, don't send him to CT scan. It's not going to add much acutely. The diagnosis is clinical. You assume that's what it is. You don't need CT to confirm it. There is high risk of destabilization during transport, during movement. and it leads to delays to fluid resuscitation, to monitoring, and to cath lab treatment. May only do CT scan with or without contrast, depending on renal function, many hours later, or rather next day, for retrospective confirmation of diagnosis in the patient who already stabilized for many hours. And when you do the CT scan with contrast next day, if you do it with contrast, you don't have to, but if you do it with contrast, the CT scan shows if there is still active bleed or not. If there is active bleed, you will see contrast stain in the hematoma. But usually in a next day stable patient, the bleed is not active. However, it could be mildly active. That's why there could be a value of doing when you do the CT scan next day. If you can do it with contrast, you can do it with contrast. It can show that maybe that RP bleed is still mildly active. There is a small area of active bleed partially concealed by hematoma. It's what I call mildly active RP bleed. That's kind of similar to femoral pseudoaneurysm that I'm going to explain in a little bit. So if active on CT, even next day, you should consider bringing a patient to the cath lab to try to seal the bleed. This is more the slow oozing, partially contained RP bleed. This is another statement from my book. By the way, a lot of those pictures and statements are from my book. CT scan is not necessary to confirm the diagnosis in a persistently hypotensive patient, nor should the diagnosis rely on a drop in hemoglobin level. The patient may fall into a progressive, irreversible shock with unnecessary delay. And this is from a paper, the 2006 Cleveland Clinic paper. Although CT scanning or other form of imaging are occasionally useful in diagnosing the complications of RPH or making the diagnosis when it's suspected, CT scanning in our experience is usually not required, and in fact, delays related to its performance directly were related to death of 2 patients in this series. They had in this series 6 patients die directly and quickly after retroperitoneal bleed, and 2 out of those 6 died directly, in their opinion, because of acute CT scanning. Peripheral vascular surgery or endovascular treatment is appropriate if blood product transfusion does not result in hemodynamic stabilization or if there is a clinically significant organ or nerve compression. I want to explain what is the interventional treatment of RP bleed and any uncontrolled active bleed, even lower bleeding. What do we do in the cath lab when we take those patients back? So here's what we do. Let's say we had the right femoral access. We stick the contralateral femoral and we cross over into the right side using a 4 to 5 French omniflush or IM catheter and a glide wire. We can do aortic angiography using DSA, subtraction imaging, and use overlay smart mask to cross over your catheter and wire into the right iliac. Then you obtain iliac angiography. And if you see contrast extravasation, then you put a crossover sheath and you plan on doing your intervention. And the way you do your crossover sheath, you put through that catheter, let's say the OmniFlash or IM catheter, you put through it a stiffer wire, such as Rosen or Amplatz wire, and then you advance a 7 French sheath. You typically need a 7 French to treat a perforation. You put crossover 7 French sheath, such as destination sheath or Cook 55 centimeter sheath. What do you do after advancing the sheath? It depends on the level of extravasation, iliac versus common femoral artery. But regardless, the immediate next step when you see an extravasation is to perform a prolonged balloon inflation with a peripheral balloon at or just upstream of the extravasation. The balloon is sized 1:1 to the artery, typically around 7 to 8 millimeters for at least 10 minutes, possibly 20 to 30 minutes if the limb tolerates. Now, if the bleeding persists after balloon inflation and the leak is at the iliac level, then you have to place a cover stent. You may place a Viabahn self-expanding covered stent, which is a flexible nitinol stent, less likely to fracture, or less favorably, you may place an ICAST balloon expandable covered stent. And the size is usually in that 6 to 8, more 7 to 9 millimeters, and you upsize by 1 millimeter if you're using a self-expanding stent. The catch here is that those stents require at least 7 French and more so 8 French for 7 to 10 millimeter Viabahn stent. So if you decide to place a cover stent, you will likely upsize your sheath to 8 French, or you could have started with an 8 French sheath up front. So for 7 to 10 millimeter Viabahn, you need an 8 French sheath. And most men will have an external iliac artery that is in this range, 7 to 10 millimeters. Now, if the bleeding persists and the leak is common femoral rather than external iliac, if the leak is here rather than here, then placing a cover stent is no longer favorable for 2 reasons. One, a stent in the common femoral artery is more prone to fracture. You may place a short nitinol Viabahn stent that will make it less likely to fracture because it's short and it's flexible, but it's only when that perforation is high up here and very localized. And the second caveat of common femoral stenting is that it precludes future access. But again, if you can place a short stent in the proximal common femoral, then this may not preclude future access. So if the bleeding persists and the leak is common femoral rather than iliac, the best treatment is surgical correction for the 2 reasons I explained. Now, if you do send the patient for surgery, remember, the patient may destabilize by the time you get him to surgery. So the way we send those patients to surgery is you keep your interventional gear and the sheath, and you keep the balloon inflated to control the bleeding while you're transporting him for surgery. And actually that helps the surgeon, that balloon. It helps him localize the bleed, and it helps him have a clean field while he's trying to fix the bleed. And he can inflate it and deflate it as needed during his surgery. So that's the best treatment. Now, you may consider for common femoral leak, you may consider a short Viabahn self-expanding stent if that common femoral leak is in the proximal common femoral, close to the iliac. You may put a short stent here that may not preclude future access and that has a lower risk of fracture when it's short. The shortest Viabahn stent is 25 millimeters. So you may consider that, but the best treatment for common femoral is usually surgical correction. Another idea here, I mentioned earlier that RP bleed could be also related to the iliac circumflex artery. Your wire went into it when you did micropuncture, or to going through the inferior epigastric artery. So it could be a leak from a branch. And so if your perforation and bleed is resulting from a puncture of a small branch such as those 2, this branch may be wired, then a catheter advanced over the wire into it, then you can coil it. And I explained coil in my prior talk on coronary perforation. You can review that. You can use Tornado Terumo coil, 0.018 inch, or Concerto Medtronic coils, 0.014 inch. You can also place a cover stent across the ostium of the perforated branch. That's a less favorable option. The better option is to put coils when the bleeding is from a small branch. Additional technical tips on treating an iliac or femoral extravasation. Always ensure that the margins of the covered stent are well opposed and sealing the edges with no leaks through the edges into the perforation. Post-dilate if needed, if those edges are not well sealed. This is the hazard of undersizing the sheath to 7 French, for example, and undersizing your Viabahn stent. And it's best to use 8 French when you decide to stent. Another very important tip is use digital subtraction in geography imaging when looking for a leak or perforation, whether before or after balloon stenting, as the standard cine imaging may easily miss leaks. Another anatomy idea here, keep in mind, we talk about RP bleed and femoral hematoma causing basically hemodynamic compromise. But keep in mind also that those large bleed may cause nerve compression. Look here at the anatomy. You have the femoral nerve running lateral to the artery in the pelvis, and you have the lateral cutaneous femoral nerve running even more laterally in the pelvis. And both those can be compressed and compromised by a large bleed, particularly RP bleed. And in fact, femoral neuropathy was seen in 36% of RP bleed in that paper from 1994. And this may happen with a groin hematoma and may cause future morbidity for the patient. So keep that idea in mind, sensory or motor deficit from an actual bleed. We don't often think about it. I will move on to a next big complication, femoral pseudoaneurysm. One, I often ask fellow, define to me femoral pseudoaneurysm. And they often give me that one answer that I absolutely do not like. They tell me that a femoral pseudoaneurysm compared to an aneurysm is basically a collection of blood that's not surrounded by the three standard layers of a vascular wall. That is an answer I do not like at all. That is a true answer, but it's completely irrelevant. It shows that you have no idea what I'm asking here. When I'm asking you to define what is femoral pseudoaneurysm, I'm asking you to define it in context, in relation to how does it compare to a hematoma? What's the difference between pseudoaneurysm and hematoma? So such an answer shows that you don't understand what we're talking about here. So define pseudoaneurysm in comparison to a hematoma. Can anybody tell me, any of the fellows here, what's a pseudoaneurysm? So next time I ask you, what's the definition of pseudoaneurysm? That is the definition. It's an expansile, non-contained actually, expansile collection of blood that has two features differentiating it from a hematoma. It is not clotted, and it remains in communication with the arterial lumen, meaning there is an active bleeding. This is a hematoma. It's a clotted collection of blood with no active bleed. It's fully clotted and there is no active communication with the lumen. This here, the white one, is a pseudoaneurysm. It's an active collection of blood that is actively communicating with the artery and it's not clotted. Now, you can have pseudoaneurysm within a hematoma. You have here a surrounding large clotted hematoma, and on the inside, you have a pseudoaneurysm that is non-clotted, active bleed. Okay, two ideas, not clotted, and it remains in communication with the arterial lumen. This is different from a hematoma, which is clotted without active bleeding. A pseudoaneurysm, there is to and fro. We call it to and fro flow with the artery. So the artery pumps into the pseudoaneurysm in systole, and there is a backward blood flow in diastole. So it's a to and fro, up and down flow between the artery and the pseudoaneurysm. Pseudoaneurysm must be distinguished from hematoma because it's an active bleed that will keep growing. And you distinguish that by examine and by ultrasound. And keep in mind that a hematoma, let's say the patient had a bleeding initially, he had a hematoma, you controlled it, you held manual pressure for 30 minutes or an hour, and you controlled it. That hematoma may become later on a pseudoaneurysm. So there is a chance that part of that hematoma may initiate intrinsic fibrinolysis, which dissolve the clot that was initially plugging the arteriotomy site. So you go from this to a pseudoaneurysm. This may happen next day. This may happen later on after he goes home. He pushes something. All of a sudden, you break and you create a communication, and now you have a pseudoaneurysm. So it may happen later on, not acutely, after a hematoma, okay? Now, how do you distinguish a pseudoaneurysm from a hematoma? On exam, two features, a bruit and a pulsatile mass. And by ultrasound, Doppler. This is how you make a diagnosis, by Doppler. It will show a mass that communicates with the femoral artery through a to and fro high turbulence mosaic Doppler flow. And this is an illustration. You will see the femoral artery and you see that collection that is a black, okay? It's like a cavity. It's not a hematoma that has a clot and it's more whitish. It's a black and there is a communication. There is flow into it. And it's to and fro. There is flow both ways, this way and that way. You will see forward flow in systole, reversal of flow in diastole. And you will be able to tell that on spectral Doppler. You need to see those two waves, to and fro. Now, you may have a pseudoaneurysm with multiple pockets, which is important eventually for treatment. This is another illustration. This is the femoral artery. This is a pseudoaneurysm with multiple pockets. Now, you have to always confirm it by Doppler, color and spectral Doppler. And you have to see to and fro. Why? Because you have to distinguish pseudoaneurysm from AV fistula. Pseudoaneurysm is frequently treated by thrombin injection, which is absolutely contraindicated in AV fistula. In AV fistula, the flow is one way from the artery to the vein in both systole and diastole. It's a one-way flow. In pseudoaneurysm, it's a two-way flow. So it's very important to know you don't want to inject an AV fistula, which will be here. It will be a vein, basically. You will be injecting it with thrombin. And some patients have both because both are associated with low stick. So they may have pseudoaneurysm and AV fistula. And you have to make sure there is no AV fistula before you inject thrombin. So for pseudoaneurysm, the risk is higher with a low SFA or profunda stick, as those arteries are not supported by bony structures and are difficult to compress. In particular, profunda, as I explained, dives posteriorly and deeply into the thigh immediately upon takeoff, making it particularly prone to uncontrollable bleed or pseudoaneurysm. Other risk factor, hypertension, age, PAD, obesity, sheath size, and 2B3A. Those, by the way, are risk factors also for any major bleed. Now, how do you treat a pseudoaneurysm? Definitely an interventional board question. If it is less than 2 centimeters, if that pocket is less than 2, especially less than 1, probably less than 2 centimeters, let's use the 2 centimeter cutoff. It very often closes spontaneously at a mean of 23 days based on those registries here. 88% close at a mean of 23 days. So what you can do in those cases, you may just watch them. You can do serial ultrasound follow-up every 1 to 2 weeks. Then if they persist at 1 month, if they grow in the interim, or if they persist at 1 month, you need to treat them. And how do you treat them? If it is more than 2 centimeters, with a favorable neck, then we have those two options. What do I mean by favorable neck? A good neck is a neck that is tall and narrow. There is no clear cutoff, but tall at least over half to 1 centimeter, and narrow less than half to 1 centimeter. Those are the cases that are more favorable to basically ultrasound-guided compression or ultrasound-guided thrombin injection. And what is ultrasound-guided compression? Basically, ultrasound-guided compression is, as you're doing your ultrasound, you see the neck, you see the area of aliasing, you exert a localized compression in one point that stops that flow. So it's unlike the manual compression that exerts diffuse global force. Here you exert focal force, less intense force, but focal, onto a point that occludes that area, that leak. And you exert that pressure for about at least 30 to 45 minutes. It is very successful. Based on registries, 75 to 90% efficacy. The problem is that it can be hurtful to the wrist of the operator, whether the doctor or the technician doing it, especially in large obese patients. So, but that's an efficacious treatment. Another treatment is ultrasound-guided thrombin injection. And this is how it's done usually. You create 1,000 units per milliliter of thrombin. So you can take a thrombin vial, powder vial of 5,000 units. You add 5 milliliter of saline to it. You have now 1,000 units per milliliter. And you aspirate with a 3 milliliter syringe that solution. And you inject very little. You inject 0.1 to 0.5 milliliter of that solution, which is, 100 to 500 unit with a small 22 gauge needle. And you inject that at the surface of the pseudoaneurysm, as far away as you can from the neck. And if you have multiple pockets, you treat the pocket that is closest to that neck. And that may collapse the other pockets. And again, in that pocket, you try to be as far away from the neck as possible. And you ensure, again, no AV fistula. Importantly, if you want a favorable neck, the wider the neck, more than 1 centimeter, and the shorter it is, less than ½ centimeter, the more likely you are to send that thrombin into the artery and cause a risk of a femoral artery thrombosis. So that's why the neck characteristics are very important. That's why there are cases where those patients need surgical correction, such as pseudoaneurysm with a wide neck, more than ½ to 1 centimeter, or a short neck, less than ½ centimeter, or pseudoaneurysm that fails thrombin therapy. Sometimes you can redo thrombin therapy if it fails, but you can consider surgical correction, especially after a second failure. Or pseudoaneurysm of a graft, or a large pseudoaneurysm, meaning the pocket is large. There is no cutoff to decide about surgery, but after I reviewed all the series, they rarely include pseudoaneurysm over 4 or 5 centimeters. Most of the pseudoaneurysm included are 2 centimeters to that 5 centimeter range. When it's large, but especially when it's large with compressive symptoms, neuropathy, don't forget about neuropathy, or arterial or venous compression, then surgical compression may be the best option. And those are some of the registries I used to get those numbers. So I want to talk about femoral AV fistula, the third major complication. So again, at the groin common femoral level, the femoral vein is medial to the artery, but then it quickly crosses under and becomes posterior and lateral to the SFA and to the popliteal artery. So at a low SFA level, the artery and veins are superimposed, and a venous stick or a venous sheath may go through the artery. Also, a posterior wall, low arterial stick may touch the femoral vein wall and create an AV fistula. Now, here is how AV fistula looks like on ultrasound. Again, at the site of aliasing, you will see one-way flow, not to and fro. There is no reversal flow. It's one way, systole and diastole. And actually, even if you put your spectral Doppler in the artery itself, it's no longer triphasic. It becomes monophasic because now it's what we call low resistance flow into that vein. So it becomes monophasic. It no longer has that early reversal in diastole. And actually, if you put your Doppler into the vein, you'll see the vein itself also loses its phasicity. How do we manage AV fistula? One, you need to know what are the consequences of AV fistula. AV fistula are different from pseudoaneurysm because it's not an active bleed that can potentially grow. The complications of AV fistula are twofold. Heart failure, whether right or left heart failure, it's a form of high output heart failure. And number two, limb ischemia, limb steal. And number three, you can get also edema from the increase in venous pressure. Now, AV fistula, what you need to know, unlike pseudoaneurysm, are overwhelmingly benign. In fact, in one JACC series, this one, the most important one from 2002, 38% of fistula spontaneously close within a year, mostly within 4 months. But most importantly, all the remaining fistula, the other 62%, remained stable without any of those complications on 1-year follow-up. No heart failure, no limb ischemia, no reduced distal pulses, no reduced ambulatory distance. As these fistula are usually small and they are usually not hemodynamically significant. They are much smaller than a dialysis fistula, so they are well tolerated. And actually, none of their fistula, even the ones who didn't close, required surgical correction. And this is another series from the 90s. In this study, even more AV fistula resolved, 81%, more than 38%, and they resolved at an average of 28 days. So again, AV fistula tend to be benign. And why are they benign in general? Because as it is when we talk about shunting across the heart, in order for you to have a QPQS of 1.5 in cardiac hemodynamics, the flow across the shunt needs to be more than 30% of the QS, of the systemic output. If shunt flow over 30%, it translates into a QPQS of 1.5, which is hemodynamically significant. But the shunt flow across those peripheral AV fistula iatrogenic tends to be 160 to 510 milliliters per minute, which is far lower than the systemic output, and QPQS ends up being less than 1.5. And it's usually a lot less than a dialysis AV fistula flow, which is close to a liter per minute. So most AV fistula are asymptomatic and do not require repair, 90 to 100%. And some close spontaneously because of that slow flow. Remember, a lot of dialysis fistula even close spontaneously. And those smaller flow fistula close spontaneously because of that slow flow. There are no guidelines on management of iatrogenic AV fistula, but based on this data, iatrogenic AV fistula are managed conservatively with serial clinical and ultrasound follow-ups, example, every 2 weeks for a month, and every month for 3 months, then every 3 months. They are surgically repaired only when there is evidence of significant shunting through the AV fistula leading to hemodynamic consequences, limb ischemia, or heart failure. Keep in mind, ultrasound-guided compression that I explained for pseudoaneurysm can work for AV fistula, but it's a lot less successful. It's only successful in about a third of the cases. So the treatment, when you need it, is usually surgical, but it's rarely needed. I'll move on to some other complications. Limb ischemia during or after femoral access. So if the patient's foot is numb and cold and no distal pulses and no Dopplerable pulses, limb ischemia may be related to occlusion of flow by the sheath itself in patient with a small or diseased femoral artery. Also, the sheath may further impair the flow of an already reduced baseline flow of any severe PAD, even downstream PAD. You put a sheath in a femoral artery that's not too bad, but you're further impairing the flow to that distal runoff, and you get limb ischemia. So the first treatment is for limb ischemia, if you have a sheath in place, is to remove the sheath and hold manual pressure. Now, if limb ischemia is not promptly corrected by sheath removal, a femoral dissection, thrombus, or distal embolization should be suspected. In this case, you give heparin, you do femoral ultrasound urgently, and you may consult vascular surgery for exploration and thrombectomy, or you or your vascular surgeon may do urgently for percutaneous angiogram and intervention through a contralateral access, potentially needing to use angioplasty and or TPA and or thrombectomy. Important idea, how do you manage limb ischemia after closure device? There are many ways of doing it. I'll tell you just my straightforward concepts here. There are two big closure device, you have the plug and the sutures. So the plug device, let's say Angioseal, the collagen plug, or Minx, the PEG plug, it causes limb ischemia when it's deployed inside the artery rather than on top of the artery. Those devices have an anchor. You open the anchor in the artery and you pull the anchor to the arteriotomy. Then you deploy the plug on top of the arteriotomy or the suture on top of the arteriotomy. But sometimes the anchor gets stuck inside the artery, so you end up deploying the plug or the suture inside the artery. So how do you deal with this? For Angioseal that is deployed inside the artery, the way I've treated it before is to use Hawk directional atherectomy with distal spider wire protection. So you basically slice this and pack it into the nose cone of the directional atherectomy using distal filter protection. Some have used a plain angioplasty. Some have used laser. There is a series about laser. And regardless of what technique you use, if there is extensive thrombus associated, you will need local lytics before you implement balloon angioplasty or atherectomy. And this is how Hawk atherectomy works. It's a directional atherectomy. It slices a plaque, or in this case, the plug, and it packs it into the nose cone. There is a high risk of embolization, but that's why we use the spider wire for protection. So basically, you're shaving that plug and packing it into the nose cone of the Hawk atherectomy. Now, if it is a perclose occlusion, basically what it means is that the suture was deployed in the artery rather than the surface of it, and the knot is tying the anterior and posterior walls together. So what you do in this case, via your crossover sheath, you wire the occlusion inside that tight suture. That suture is tying this. You try to slip a coronary wire or 14-inch, possibly a polymer coronary wire, through that tied knot, and then you progressively dilate the knot from 2 to 5 millimeters. Eventually, you try to break that knot, and that's how it's usually treated percutaneously. It's actually easier to treat than the plug devices, but it needs to be recognized quickly before you start having extensive thrombi. Another complication, that's a board question as well, very important for your clinical practice, retrograde iliac dissection. So I'm going to give you a case. A femoral access is used to perform a planned PCI. Difficulty is encountered during iliac wiring. Femoral angiography shows that the sheath is properly positioned in the true common femoral lumen, but the external iliac artery has a flap. So the external iliac artery is tortuous and has a retrograde non-flow limiting dissection. What is the next step? Basically, you created a dissection in that iliac artery and you're seeing a flap now. That dissection may be due to your wiring of a tortuous artery, tortuous calcified artery, or potentially to your angiography itself. If you do your angiography, your femoral angiography via a stiff sheath pointing to the arterial wall, you can create hydraulic dissection. That's why you should always, when you're doing your femoral angiography, one, make sure you have pressure waveform through your sheath before you inject. And number two, don't use a stiff sheath to inject. Some micropuncture actually sheath are very stiff in some brands. Do not use those to do your femoral angiography. It has to be a soft micropuncture or a soft sheath. So what do you do when this happens, that retrograde iliac dissection? You're trying to do a PCI. Abort the procedure, remove the sheath, and hold manual pressure. Attempt the wire the true lumen using GR4 catheter and proceed with PCI as planned. Remove the sheath, then perform the procedure through a left femoral or radial access, or stent the external iliac artery. This is the answer. This is, by the way, from my book. The answer is B. Attempt the wire the true lumen using GR4 catheter and proceed with PCI as planned. This is the idea here. Retrograde iliac artery dissection may occur during retrograde wire advancement or even sheath angiography in a tortuous iliac artery. Contrast injection through the sheath may create hydraulic iliac dissection. If that dissection is non-flow limiting, it is treated conservatively. Because remember, it's a retrograde dissection. So the blood is flowing this way. So the forward blood flow will tend to tuck the dissection and heal it with time. The key is to avoid rewiring the dissection plane and further aggravating it and expanding it. As long as the true iliac lumen can be wired, the procedure does not need to be aborted and the patient does not need to be exposed to the risk of a second access. So again, retrograde iliac dissection may occur with wire advancement. It is generally benign and seals with the antegrade flow. Do not abort your procedure. Eventually use manual compression for hemostasis, not closure device. I will move on briefly to describe some radial access complications, which luckily are rare and more benign. So radial artery pseudoaneurysm, we see it occasionally. It can occur in up to 0.2% of transradial PCI based on the Radial trial. Most small pseudoaneurysm, less than 1 centimeter, close spontaneously, like I mentioned with femoral pseudoaneurysm. With femoral pseudoaneurysm, up to 2 centimeter frequently close spontaneously. Here, it's up to 1 centimeter. For pseudoaneurysm more than 1 centimeter, how do we treat them? The most common treatment for radial pseudoaneurysm is actually to put back a transradial band for several hours, about 3 hours, and you try to make it fully occlusive of the radial artery for some duration of time as tolerated, maybe 10, 30 minutes, fully occlusive if tolerated, and you keep it on for about 3 hours. After that fully occlusive period, you maintain patent hemostasis, meaning you either have a radial pulse below the transradial band or you have an oximetry waveform, even if you occlude your ulnar artery while your transradial band is on, meaning you have a radial flow. That's what we call patent hemostasis. So this will often successfully occlude the pseudoaneurysm. So unlike femoral pseudoaneurysm, we rarely would consider thrombin injection for a radial pseudoaneurysm. It has been described, but there are no large series of that. There are mostly case reports of it. So it's a more questionable treatment. Why? There is more concern about hand ischemia with thrombin injection. Particularly, of course, same idea. If you have a wide neck or a short neck, risk of thrombin migration into the radial artery and the hand. But even without that, a radial artery has a higher risk of thrombosis in general. It's a smaller size runoff compared to the lower extremity, femoral and below circulation. Two, the vessels are smaller, so higher risk of thrombosis or consequential thrombosis. It has been described, but be careful with that consideration. You can consider ultrasound guided compression, but also, unlike femoral pseudoaneurysm, it's often unsuccessful, probably because you have no pannus in that area, so no tissue weight to compress the neck. So really what works best for radial pseudoaneurysm that is more than 1 centimeter is placing a transradial band for that several hours period. And if that fails, it's surgery. And again, unlike femoral pseudoaneurysm, surgical repair of radial artery pseudoaneurysm is an easy procedure because it's a shallow superficial surface. So it's a relatively straightforward, and you can keep a low threshold to doing that if it doesn't heal with TR band. Another complication, radial artery hematoma. The key is early detection, very rare progression to compartment syndrome, 0.004% based on registries. For small or large hematoma, the immediate next step is usually to inflate the blood pressure sphygmomanometer immediately proximally in the upper arm or in the forearm above systolic blood pressure and maintain it there above systolic blood pressure. Then you can either proximally reposition the TR band or add a more proximal TR band. Frequently, the hematoma results from the fact that your TR band is not properly positioned. It might be a bit too medial or lateral or a bit too low. So you inflate your blood pressure cuff and you reposition TR band, or easier, you add a more proximal TR band. The key is early detection. An important and last idea, when you have a compartment syndrome after a radial access, what is the usual cause and what is the immediate thought reflex? So when you have compartment syndrome, is it usually due to an access hematoma? Here is the answer. When you have compartment syndrome for radial access, it's usually not related to the access itself. This distal access, it will be very hard for it to cause compartment syndrome. This is what it's usually due to. And I explained that in a prior talk about radial tortuosity that I suggest you review, radial loops and tortuosity. Radial-related compartment syndrome is usually due to perforation of a branch at the forearm level. You have a loop at the forearm level, and usually when you have a loop, a radial loop, you have a small artery that arises from the belly of the loop and that goes all the way up. And frequently, when you have a loop, your wire tends to go into that straight artery and perforate it. So most often when you have compartment syndrome from a radial access is due to a complication from your wire and catheter maneuvering at the forearm or arm level, especially perforation of a small recurrent branch arising from a loop, which you need to recognize during the procedure. This should not happen that you have compartment syndrome after your procedure, because you need to recognize it. And I explain in this talk how to manage it. So when you encounter difficulty and you use some tools to navigate that loop or that tortuosity, you will need to do digital subtraction angiography, and it may identify a leak that happened during your initial maneuvers. And I explain how to deal with that. Usually the way you deal with it is that you continue your procedure. You just, even in intervention, you just advance your guide across, and putting devices across that area that has a branch with a leak will tamponade the leak. At the end of the case, you repeat your digital angiography. Most often the leak is stopped from that guide catheter tamponade. If it doesn't stop, you can re-advance your guide and inflate a blood pressure cuff for 10 to 20 minutes. If that fails, you may consider using coronary wires and coronary balloon inflation across the area where there is a perforation for 20 minutes. Eventually, you may consider surgery. But this needs to be recognized during the procedure and treated during the procedure. It will self-tamponade usually by continuing your procedure and placing catheters across the area that is leaking.